All right. Good afternoon. This is Kevin Kirkpatrick, CEO of the Avery Professional Group. Today I have the honor of having Dr. Michael Gardam as our guest. Dr. Gardam is the CEO of Health PEI. I know him from when he was Chief of Staff at Humber River Hospital in Toronto. Luckily for me, I get a chance to work with him and his team, recruiting physicians. So what I wanted to do today was cover off two things. One is talk about Dr. Gardam's progression from clinician. He's an infectious disease physician and internist into leadership, and then talk about Health PEI and the reasons why somebody needs to come to the island. So
Sure.
Thank you for joining us, Dr. Gardam.
Thanks for having me. Great to see you again.
You too. This time we're virtual. You're in the lovely PEI, and I'm sitting in Toronto. So I'm going to have to admit to being a little bit jealous. So
no, there's very little traffic here.
Yeah, I was the 8th person in line to Tim Hortons today, so that was my biggest foray into traffic.
Yeah,
Otherwise,
it is a very different lifestyle in terms of traffic. I mean, I just dread thinking flashbacks of sitting on the 401. I do really enjoy not doing that, I have to say.
Yeah, well, when we worked together, I had an hour and a half commute each way.
Yeah.
Right. So, and that was all 401. So
yeah, and those are hours you're not getting back, my friend.
No, and they're not productive. You know,
No.
it's not like sitting on the train checking and sending emails. You're bumper to bumper. I think I was usually more stressed by the time I got to work than when I was at work. So,
and if you remember, my office was overlooking the 401, and I would sit there, and it'd be 7 o'clock at night, and I'd look at the 401, and it's not moving. And I'm like, well, hell, I guess I'll wait another hour. I'll go home at 9.
And just keep working to avoid it. So, Can you give us the elevator pitch of how your career started and how you got to sit in the CEO chair?
Sure. I mean, it's kind of a roundabout story, but I mean, basically, I went into medicine like all of us go into medicine, which is to see patients. I never really wanted to be a researcher per se or anything. I just wanted to make a difference and help people. And I got into medicine a bit later. I was doing a PhD in biochemistry and then changed my mind in the middle of it and went into med school and went through all my training in Montreal. And then I was asked to be chief resident. And that was the first time I had been put in any sort of leadership position. And I really liked it. Like, I really liked thinking of the bigger system and how do we schedule people for call and how do we make sure things are working. And that kind of appealed to me. And I had never seen that before. So I finished that year. I went on and did ID micro. And then I got into, working in infection control, and I was at UHN in Toronto for roughly 20 years, running the infection control program there. And then I did a stint at Public Health Ontario, where I was the head of infectious diseases during the H1N1 pandemic. And it was really around that time that I got into more sort of physician leadership training and interest. And I got asked to be the MAC chair at UHN, which is the big committee that all the doctors sort of participate in terms of quality of care in the hospital. That put me on the board of the hospital for 3 years. And then I said, okay, this is actually where I want to be. I like seeing the big picture stuff. So then I applied to be chief of staff at Humber. And then I was here doing consulting work on physician leadership and got asked to be CEO. And that's how I ended up at CEO. I never planned to be a CEO, and I never planned to be in PEI. It was all kind of, that was the opportunity that was there, and it fit with what I was doing at the time.
Excellent. What is the I could ask this two ways. What is the most challenging thing about going from a physician to physician leader, and also what's the most rewarding thing of that?
Yeah, I mean, the most challenging thing is historically physicians can be a little bit suspicious of physicians who go into leadership positions, because we still have this way we kind of judge you based on your sort of clinical work and that kind of thing. So that can be a bit of a challenge, although I haven't really found it that big a deal personally. I think for me, the hardest thing is, as physicians, we're laser focused on the patient. And when you get into leadership roles, you realize there's 20 different lenses that you need to look at right? It's not just the clinical thing. It's not just this, it's not that. So in a job like mine, politics are a big one. Labor relations are a big one. Helping my senior team work well together and, enjoy their jobs and be highly functional, getting them the supports that they need. And, so there's a hundred things. And the fact is the physicians might need more resources or whatever else, but it's one of the things in this huge environment that you have to consider when you're in leadership. Whereas when I was a frontline physician, it'd be like, why the hell can't you just give me another nurse? I don't understand.
Right.
Right.
What do you mean it costs more money for more
What do you mean?
nurses?
Yeah.
Right.
Like why can't you just do that? And the answer could be surprisingly complicated, but
Yeah.
it's almost never because I don't want to give you a nurse.
Yeah.
There's usually a bunch of other stuff going on. And part of the things I try to do is I try to be very transparent with people and explain why something that looks simple might be very difficult.
Hmm. Yeah. Excellent. What has been the most enjoyable, other than our previous discussion about traffic and such? What's been the most enjoyable thing professionally about PEI?
I really, really like the people I work with. I've liked the people I've worked with everywhere I've worked. Here, um, I just find you've got a really dedicated senior leadership team that could easily be hired elsewhere. And they're here because they want to be here. Some of them are Islanders, some of them are from the Maritimes, they may be from wherever. One of my executive directors worked for years at TGH in Toronto, so worked at the big hospital in Toronto, and but they're here for whatever reason, and they're really dedicated, and they're fun people to work with, and I really enjoy supporting them. I see my job as pushing the boulders out of the way for them so they can get to where they need to go. And that's been what's really kept me here.
Okay.
It's a really great team of people. And I like the fact that when I worked at UHN, right, you had access to everything. You need somebody who only operates on the left-hand side of the hypothalamus. Yeah, we got one of those. Whereas in PEI, you don't have that. And so it's more of a, to some degree, jack of all trades, having to get involved in a whole bunch of stuff that you're not quite so specialized. And I really like that. I really like the fact that we get pulled in these different directions to try to do different things, as opposed to UHN, where it was very understood what you were doing there.
Yeah, and we see that with a lot of clients versus the big city versus 2 hours out of the GTA or out of the
Yeah.
larger cities is the diversity of practice expands because you don't have the volumes and such to subspecialize so much, right? And I
Yeah.
think a lot of the newer physicians, and this is anecdotal, I haven't seen any research on this, but a lot of the newer physicians enjoy the diversity of the clinical nature of it, right? As opposed
Yeah.
to being subspecialized in one area. And I think it's a more sustainable thing, right? Like if you're constantly seeing new things and seeing a larger breadth of things, then your ability or the speed at which you get burnt out, maybe it lessens, right?
That's right. And I think that I mean, all of PEI is rural. It's kind of a interesting little mix because we're the most densely populated province in Canada, believe it or not.
Mm.
Every hill you drive over, there's another house. You're never stuck on the highway with nobody around. Like there's always people around, but we're small and our hospitals are relatively small if I compare them to something in Ontario. Um, but it has this sort of cohesion to it, which makes it just a very interesting place to work. It's just
Mhm.
there's and but if you want to be a subspecialist, if you want to come here and you only want to do back surgery, it's probably not the place for you because we don't have the volumes. And so
Right.
we've occasionally had challenges with that in the past where we've brought in doctors and we should have checked further, like, are they happy being more of a generalist or do they really want to be subspecialized? Because if they do, want to be subspecialized, I'll hand them over to my colleagues in Halifax.
Yeah.
And say, this may be the better place for you, because I don't want to bring you here and then have you get frustrated because you can't do the really focused stuff that you want to do. Like, look at me, like my clinical practice in Toronto is only tuberculosis.
Right.
I have no future here as a tuberculosis physician.
Right.
I think we get one case a year. That's not going to work.
Yeah, no. And it's interesting. I had the luxury of meeting a couple of your internists this week and talking to them about, internal medicine opportunities in PEI. And it was interesting to me because of the two major hospitals that we discussed.
Yeah.
The breadth of practice and the potential breadth of practice is greater than what we're seeing in parts of Ontario, for instance. Because right now, we're seeing internists that are, working as hospitalists, yes. Right? Because it's an easier funding model and they just do inpatient. They don't have to worry about doing any outpatient work because it seems like a lot more want to be in the hospital than in an outpatient environment.
Yeah.
But whereas when I talk to the team in, two of the team in PEI, like one doctor's doing ICU as well as, consults as well as outpatient, right? So the breadth of experiences, is definitely there. And, like they're talking, it's not a massive ICU, but it's a 10-bed ICU. So, yep. Or 8 with the ability to go to 10. So, there's a lot of different potential there where in Ontario, you might not be able to do ICU unless you're an intensivist and it's because it's a closed ICU. So the career growth and the clinical growth is probably better in somewhere like PEI than a lot of the places in Ontario, right?
Yeah, and you're going to, if you're an intensivist, you'll do ICU, but you're only going to do ICU.
Yeah.
Whereas here, you do have the option of doing a variety of different things. And I mean, PEI's in a bit of a growth spurt right now. We're the fastest growing province in Canada, and we're also looking at our older models. We're now challenging them and saying, do we need to have a line of people that only do ICU? And part of that depends on what's the job market like. Do people want to do that? Because if people want to do that, they can do that here. If they don't want to do that, we may find that over time we have to change our models to meet whatever the workforce is, right?
Well, that's you know what, I if I could put a pin in things, I would put a pin in what you just said, because what I'm finding a lot with organizations is that the organizations that understand that they need to be physician and candidate driven are having a much easier time recruiting than those that are saying, well, this is what we need, find somebody like this. Because the reality is we have a scarcity and we're in a candidate driven market, right? Like I talked to a physician the other day who said, I get 9 emails a week from recruiters, right? And I was one of the 9. So thankfully they responded to my emails, probably the 3rd time I emailed them. And, so when the opportunities are plentiful, it comes down to an onus on onboarding, an onus on fit, and giving them the opportunity to really build the career they want, right?
Yeah, that's very important. And I think we are becoming more and more open to what is it that you want to do, right? And as long as you're not telling me you want to do cardiac surgery, which we don't do here, so this is not the place for you. But if you want to do something that we need, let's say you're an anesthetist and you want to provide anesthesia in the OR, but you also want to set up a pain clinic. Awesome, right? We can flex with that. Or you want to come here and you want to work 3 days a week because you've got young kids. Great, we can pull that off very easily.
Yeah.
We have a very high percentage of our doctors who are actually salaried, that actually come with the benefits and everything else that goes along with it. Or you can be fee for service, or you can be contract, or you can be a combination of these, whatever you want. Because we are trying to make it much easier for people to see themselves doing what it is they want to do and not being sort of stuffed into the wrong hole.
Yeah. Well, it's interesting because the salary thing, is kind of an interesting scenario, because as we look to candidates in the UK, for instance, that might be looking to move to Canada or move to PEI, having the safety net of a salary and benefits and stuff like that, makes that transition a little bit easier, right?
Yep.
Like saying to somebody, oh, uproot your family and come be fee for service, it's a little bit more daunting, right? Because
Yes.
you're going to wait a month, do your billings, and then maybe get paid a month late after that. Like it's just a bit scarier. And I think I haven't been a huge fan of incentives, because I don't think you should try and pay someone to come to your organization. But I've always been a fan of removing barriers, right?
Yeah.
So that's where incentives potentially come in. But it's looking at, okay, can we pay for licensing? Can we pay for relocation? Can we pay for additional training that they might need, right? Like, what can we invest in that person to allow them to have their career they want here, right? And we both worked at Humber, and one of the few things that I really enjoyed at Humber was that there was access to education, right? Whether it was the Schulich health management course, or sending nurses to do their critical care courses, right? Like, it was one of the things that probably kept their retention from getting bad, was because people could grow their career within the organization, right?
Yes.
And I think often that's something that gets overlooked with physicians, is we're saying, okay, I need you to come here and I need you to be an anesthetist for 30 years. Well, it's like, okay, well, hang on, like, is that person going to want to do that for 30 years? Are they going to have academic research, or are they going to have leadership plans and stuff like that? So it's like, if you aren't looking at your team and figuring out how to grow them as they want through their career, that's when we get attrition, right? And when half the time we can probably find them what they want where we are, but it wasn't a discussion that ever happened, so therefore they didn't know it was a possibility, so they go somewhere else. Right.
No, that's exactly right. And so in my mind, it's simply a matter of do whatever we can to make the career that you're looking for up to a limit, where if you get into the really highly specialized care, we're just not the right place. And even then, what I try to do is say, okay, maybe you work 80% of the time with us and you go once a week to Halifax for a week and you do something there that we don't do. Like, I've got a good connection with my other CEO colleagues across Atlantic Canada, and I have those conversations, saying, listen, I can use 80% of this person, but they got 20% of what they do that has no right being on this island. Can we do it where you are, right?
Yeah, it comes with, and I think it comes with identifying the right people, right? Like, if someone wants to work at St. Mike's or Unity Health in Toronto, then Health PEI is not the fit for them. So there's no point chasing them, right? But there are people that have the right demographic that would fit in the environment and stay. But then you're right, like, having that ability to call up, call them in Halifax and say, okay, I have somebody that wants to do
trauma surgery.
Trauma surgery. That's like, okay, well, great. Like, I'll do my hernias 4 days a week. And then I'll do my day a week or my week a month, or however it's scheduled in trauma, to keep those skills. And that's that's the way we keep people within our organizations, is identifying and focusing on what's best for them, right? Yeah. So awesome. And the house prices in PEI are much better than other places, right?
Well, let me tell you, like, when we came here, I sold my condo in the Distillery District and bought a house on the ocean, where I look at Nova Scotia every day on an acre. It's a 10-minute drive to work. Like, if I was going to buy that house in Oakville on Lake Ontario, probably $15 million.
Yeah.
And so it is a very different world. If you're coming from one of our larger cities, it's a very, very different world. And I mean, I have to say, PEI is incredibly pretty, especially during the summer. It's just an incredibly pretty province. It's the rolling hills and the farms and the this and the that. And I have a lot of colleagues who came here, bought hobby farms, do their medicine, and they have an orchard. They grow apples. They do this. It's a really different kind of lifestyle from what I would have had when I was in downtown Toronto, for sure.
Yeah, it's interesting. I have relatives in Newfoundland that we used to visit a lot, and I remember one summer going there for quite an extended period of time and enjoying it. And I've gone to MUN for career fairs and stuff like that. Like the East
Yeah.
Coast has just got its own culture, right? And
Yep.
PEI, I'll be there in 2 weeks, so I'll get to enjoy the environment as well. But it's it's nice to know that you can have a really good clinical career while having the life outside of it that you want to, right?
Yeah. And my chief medical officer and I, Kathy McNally, we're doing a lot of work to address a lot of historic issues in PEI. For example, we're trying to land a formal agreement with Halifax so that our doctors aren't spending all day on the phone trying to find a doctor who can receive their patient because they have to transfer somebody because we don't
Mhm.
do it here. To
Right.
just say no, we have a formal agreement, like it's sorted out. PEI's never done that before, and so
Okay.
we're very big into partnerships. Another example would be the one license for all of Atlantic Canada. Right, once you got a license, you are eligible for licensure here. You don't have to go through the process again.
Yeah.
Like we're starting to think in terms of partnerships, which is, it's always been kind of the Atlantic Canada way, but not in health per se.
Right.
So we're now really driving it with health to say, listen, we're small. We can't be all things to all people. And so we need to connect with bigger provinces to get all of the complete care that islanders need. And that takes some of the stress off the doctors that are here,
Yeah.
knowing
That's
that there's somebody out there who can see your patient if they're really sick.
Yeah, it's interesting because I listened to this conference based out of the U.S. and they were talking about the gig economy and how that related to physicians. And then I take that and then I think to myself about a lot of the physicians that I talk to that want to locum and how there is this trend of wanting to locum and work in multiple places
Yep.
and things of that nature. And then the Atlantic Registry is a great first step, but I still think as a country we need pan Canadian licensing because why is it
Yeah.
that we're not drawing on the physicians elsewhere? And I mean, I talked to well, actually, sorry, one of my recruiters talked to a couple of surgeons in Calgary that are working part-time because there's not enough volume for them, right?
Right.
So, what if there was another province that was struggling to have that specialty that they could,
Right.
fly in, fly out, right?
Yeah,
And stuff.
it's interesting. I'm just writing a blog post for the Canadian College of Health Leaders, and that's one of the things that I actually talk about is, I mean, historically we've had provincial licensure, partially because it's a provincial responsibility and all that, but
Yeah.
partially because it's a wall,
Hmm.
right? You can control, if you have too many doctors, you can control the number of entries, whereas if it's a Canadian license, you could theoretically go anywhere. Yeah, fair enough. But Canada also has per capita one of the lowest numbers of doctors of any developed country.
Hmm.
So, are we really going to get to the point in my career lifetime where we have way too many doctors? And if you
Yeah.
do, then they're not going to make much money and they're going to go elsewhere. Like the market will also sort that out. And so,
Yeah.
breaking down some of these historic barriers is going to be really helpful to making our overall Canadian system better.
Well, and it's interesting because physician shortages are a global issue, right? Because
Yep.
in Canada we're recruiting from the UK. Well, the UK is recruiting from somewhere else, and
Yep.
we're recruiting out of the United States, and they're recruiting people into residencies from somewhere else. So, the reality is that I think you get to the point where you know, like all of a sudden there'd have to be some way of getting 10,000 new physicians.
Yes.
Um, per annum for a couple of years to meet the need. And the other piece is Canadian training is so highly regarded that people could easily go to New Zealand, Australia, the UK. They can go to the United States.
They
So
can go there much easier than those people can come here,
yeah, yeah,
right?
exactly. And it's interesting because I do think that we will get to pan Canadian licensing at some point because the pressure will be such that there's no other choice.
Yeah.
Because we're seeing it in Ontario right now. The regulations for IMGs to coming into Ontario has the bar is not the bar, sorry, the process has been augmented and
Yes.
changed drastically. So what's happening is things that used to be deal breakers are not deal breakers anymore. So
Well, you look at the there was a story on CBC about a Canadian who trained in Australia,
mhm,
did her residency, wrote her exams, practicing in Australia. Good luck coming home.
yeah,
Like to me, that's a travesty.
yeah,
And I'm sorry, but if you were successful in Australia or the United States or New Zealand or Ireland or the UK, other countries that have systems very similar to ours,
mhm,
why are we making you rewrite exams? Why are we making you jump through all these
yeah,
hoops? And the argument has always been safety, but I honestly think that's kind of garbage. I think it's really about protectionism, and I think
yeah.
we need to knock down some of those barriers.
Yeah, and I think it's funny. Those are the normal cases, but there's also anomalies. Like I knew ICU physician in New Brunswick. Okay, looking after like a New Brunswick or Nova Scotia, I can't remember, but he was managing a 24-bed ICU. All right, but he had been trained abroad, got a license in that province, and he could not come to Ontario
Yeah,
unless he had a supervisor. So, and
right,
at that point, he'd been practicing in the Maritime Province for 12 years,
right,
right? So you've had 12 years to see his clinical performance, and you're now like, oh well, he needs someone to supervise him. So, it's ridiculous. And then my other favorite pet peeve uh, is fellowships,
yeah,
right? Like we have this lovely habit in Ontario specifically, where we let physicians come and do a 2-year fellowship in something in Ontario, usually in an academic center in Toronto,
yeah,
because they're the ones that can get the license. So that person then practices for 2 years, and again in a Canadian hospital. Once their fellowship is done, they no longer qualify for licensure.
right,
So I've had people that have had to go back to their home country, even though they've been providing care to the Ontario public
right,
safely for 2 years. Now all of a sudden the
right.
switch is turned and they can no longer do so. Right. So those are the challenges I think that we're going to get through now because there's the political capital and the political will to make changes because of how desperate the situation is. So
Yeah,
knock on
and
wood.
you know what's interesting, right, is that a lot of this, Kevin, isn't even about because there's always the ethical dilemma of should we be poaching doctors from other
Yeah.
countries? Even if you were to simply make it easier for Canadian citizens who trained elsewhere to come back to Canada,
Yeah.
now you're not poaching other nationals. But if we are recruiting other nationals here, we should make it easier for them too. Like,
Yeah.
why are you trained as a thoracic surgeon and you're driving a taxi? Well, the
Yeah.
answer is because we've made it so impossible for you to get licensed here,
Yeah.
right? And we've done this.
Yeah.
This is
It's,
a Canadian thing that we've done, and we have the ability to change it. You
yeah.
don't want to make it a free for all, but we have the ability to break down some of these barriers for sure. And
Well,
hopefully the
and
pandemic's going to let us do that.
yeah, and I also think that part of it is investing the time and understanding training and other models and ensuring that you understand the training in other places, right? And Saskatchewan did that. They went to the UK and realized that the MRCGP for family physicians was good quality training, and they've been letting people come in for years, right? So.
Yep.
Um, some of it is investment, and you're right, because we have Canadians that go to the Caribbean to train. There are a large number of Canadians doing medical school in Ireland,
Yep.
to the point where the Canadian Association of Staff Physician Recruiters has arranged a conference in Ireland for
Well,
communities to fly to
yeah.
Ireland and try and bring these Canadians back,
Oh,
right?
it's
And
crazy. I mean, I worked for the Irish government for a few years as a consultant and did some talks at the Royal College of Surgeons of Ireland. And if you're hanging around Temple Bar or anywhere there, there's a lot of Canadians.
yeah,
And they were telling me like 40% of their classes could easily be
yeah,
Canadian students.
yeah,
And the sad part is that most of them are not coming home.
no, No, well, and there's multiple aspects, right? Like, if you spend 8 years training somewhere, you may have met somebody local
Yeah.
and be in a relationship, or you may just be at a point where you're comfortable and happy, right?
Yeah.
And historically, so I've been recruiting in healthcare since 2004. So I don't know what that's 19 years, and
Yeah.
I've recruited people from the U.S. To Canada. Most of them were Canadians coming home because their parents were getting older
Yep.
and they wanted to be close to home, right? But that's the last bit of their career, not the bulk of their career,
Yes.
right? And you can't build a recruitment strategy based on, everybody's parents are going to get older, so everybody will come home,
That
right? Like,
is actually one of our number one recruitment strategies here.
okay.
We're trying to make the parents age faster.
Right. Yeah. Can you please smoke and drink a lot so you age faster? Right. Yeah. I don't know if that's really good for
That's
health
probably not a good
promotion.
thing, eh?
No,
Yeah.
I'm gonna suggest that's not the best strategy, but
Yeah.
but it's true. Like, it's looking at the demographics, and I think for too long we've stopped looking at the role of the physician and how their day and how their work, and this goes for nurses and stuff as well,
Yeah.
right? So
There's a tendency to think of our healthcare human resources like they're widgets.
yeah,
And I make that comment. I have a slide when I give talks of, are you a widget? Do you work in a widget factory?
yeah,
We're not widgets. We're all individuals with our own interests and everything else. And a doctor is not a doctor is not a doctor. They're a human being first.
yeah,
And so really taking that angle of is this province the right place for you, or is this hospital or healthcare system the right place
yeah,
for you is critical to whether
yeah.
someone's going to be happy or not.
Well, and it's interesting because you mentioned the widget, and I mean, I'm not a clinical guy, so I come from the business side of things, and I sometimes catch myself thinking of things as a unit of work and
Yeah.
whatnot. But it's still, it's applying. If you apply that logic, you then have to apply the next step, which is how do you take care of the people that are building the widgets, right?
Yeah.
And if you were working on a factory line, they're going to get you a mat so that you're not standing on concrete. They're going to get you a back support so that you can stand there. They're going to take care of you because of the productivity, right? And for them, it generates a greater income. But the same can be held without the income piece for healthcare, right? If we take care of the nurse, then she works 30 years and not 25. Or we take care of the nurse, then she doesn't have to get into occupational health because she's had a back injury, right? Like, it's, until we learn to take care of the people that take care of us, we're going to constantly be trying to push around a peg in a square hole. And we don't get the same volume and the same quality of work because the people providing the work are not in a position where they're being supported, right? And like, there's a big talk about nursing agencies now, right? And the sole reason that nursing agencies exist are two things. One, it pays better, and B, flexible scheduling.
Yep.
Guess what? Both those can be accomplished by the hospital directly without a for-profit firm in between the two.
Yep.
Right? We've had float pools and nursing pools. We just need to stop trying to control people by putting them into you must work X number of shifts.
Yeah.
But what that means each hospital has to have a bigger pool of talent. Well, to do that, you need to build a culture that takes care of them. If you take care of them, then there will be more for you to access, and you can provide the flexibility and stuff. And we need to constantly evaluate what we're paying, right? And I know it's a public funded system, but at the end of the day, I think we're paying the money. I just don't think that we're using it in the right places.
Oh, the literature says that we have one of the more expensive healthcare systems in the developed world, but I agree with you. I don't think we're using it appropriately, and I don't think there's been enough of a focus on worker safety and worker supports. We've been doing a lot of that work here since I've been here the last 2 years, and so we're rapidly, changing the narrative around, which I think used to be, what can this doctor or what can this nurse do for us? It's now, what can we do for you to keep you happy and healthy? Because ultimately, if I have happy, healthy doctors who love their jobs and love, like, I'm going to win that. Like, that is fantastic, right? And that's what I want. What I don't want are upset people who don't feel they're paid well or aren't being treated properly. So that's definitely a win-win, and we're pushing very hard on that here.
Amazing. Excellent. Well, Dr. Gardam, I am going to thank you for your time.
Thanks so much.
I appreciate getting the opportunity. I know you're on LinkedIn, so people can check you out there, but anybody that's interested in PEI or learning more about opportunities in PEI, they've got a great HR team that is always happy to talk. So you can reach out to me and I can make some connections and introductions for you. And then hopefully you can spend some time in the island.
That would be great. We would love to see some people and take them around. I've met with a number of doctors across the country who either want to come home or they're interested in a more rural lifestyle, and I take them out for lunch and show them around and show them what the place is like. Always welcome. Always happy to do that.
Sounds good, sir. Well, listen, have a great day. Thank you for joining me.
Thanks for having me.
Take care.